Well, everyone on the call, good afternoon. I'm Dennis Kuo. I'm the Vice President of the Arkansas chapter of the American Academy of Pediatrics. And I want to welcome you to this afternoon's webinar. This is the Patient-Centered Medical Home and Introduction from the American Academy of Pediatrics Arkansas chapter. Kristen, can you give me the next slide, please? And I want to begin this afternoon's presentation with a disclosure that the Arkansas AAP is being supported by a subcontract from Arkansas Medicaid Department of Human Services to provide peer-to-peer support for providers implementing the patient-centered medical home. And some slides today are provided courtesy of the Department of Human Services. Next slide. The objectives for today's webinars are we're going to do some introductions. I will provide an overview of the patient-centered medical home from a conceptual as well as a standpoint of how it is being implemented in the state of Arkansas. We're also going to summarize some of our experience to date since the PCMH has been going on since January. And we will discuss some of the deadlines and processes for enrolling for next year. We're also going to hear from our colleagues at Qualis Health regarding the support that they have been providing this year for practice doing practice transformation through the PCMH, and then we'll conclude with any questions that folks might have. Next slide, Kristen. And on the phone, we have not only myself, we have Dr. Orrin Davis, who is a practicing pediatrician at Northwest Arkansas Pediatric Clinic in Fayetteville. And I'd like to turn the phone over to him for just a few minutes just to give some overview of his thoughts on the PCMH.
Okay, I'm on a headset, so this is new for me.
Okay, we can hear you.
Perfect. Well, I think there's a couple different things. Dennis, I think, is certainly going to provide some more nuts and bolts and structure in regards to how this is supposed to look and how we're going to work on implementing it in practice. And I've thought more about the PCMH from a practice perspective in regards to trying to sort of anticipate how things are going. I think often, just for those on the call, this is a little bit overwhelming. It's a lot that comes really fast. But what I'm trying to sort of keep in mind in our practice is kind of two different things. One, I think it's important for the physicians that are on the line that are participating. I think that my goal in my practice certainly is to provide a system of care in our practice that helps me make decisions on actionable items, and that I'm not creating a system that's making me do more. I think that the EMR rollout certainly has been something that's very time dominant in my practice. So I think that's where, from a practice standpoint, that we're focusing on using the people in my office to certainly facilitate this process and bring me good information, and that I'm not sorting through 15 different faxes from 15 different physicians. And I'll pick on children's for a moment, and realizing that I've just now had the 15th chest x-ray report on the same chest x-ray. So that's one. And then I think the other thing about the PCMH that I think of is more sort of a global and where our payer sources are going. I think that we work in an environment where we have pressures constantly regarding how we're going to be paid and how they think we deserve to be paid. And the reality is both our private payers and our public payers are looking to develop something that looks different. And I think most of what we're seeing as this is rolling out is there's going to be something that's going to be similar to the process that PCMH is working on, which is sort of an average cost of care per patient, that if you can manage those families well and take good care of them, then if you realize some savings, that they'll share that with you. And I think this is our opportunity to get a little bit of some management money from Medicaid as we kind of dip our toe in the water and we kind of start wading into the ocean. And Dennis, that's where I would start. I don't know if there's more that you want to focus on now.
No, I think that's great, and I think we just wanted to give folks a couple of different perspectives on the PCMH, and I appreciate, I think also at any point during this presentation, I think that, or please feel free to jump in with any comments or observations that you have as well. I think that folks would appreciate the different perspectives. Me being here in Little Rock and you're being up in Northwest. Our Executive Director, Amy Ollinghouse, is on the call, and our QI Specialist, Kristen Pfeiffer, is also on the call. If you want to say hi.
Hi, this is Amy, and I just would say that I appreciate all of you guys for taking time out of your day and your practice to listen in on this webinar and get kind of a better idea of PCMH and perhaps the benefit it can provide you guys right now in your practices, and just would reassure you guys that we're here to help you facilitate the process and be successful in the program to the extent that we can. So that's about it.
Awesome. Thanks, Amy. Kristen, you are the contact, the main contact for folks. And for folks on the call, I think you've already heard from Kristen, and if you haven't, you will get to know her very well. We appreciate all the work that you've done. Kristen, next slide, please. I want to start with a little bit of background about the medical home. I think it's important to recognize where it came from and where it's going. Let's go back to 1967, when that is the first time the medical home term was actually used by the American Academy of Pediatrics, and it was actually used to denote a central source of records for children and youth with special health care needs. And it wasn't until the mid-70s we started seeing the medical concept being applied to community-based primary care, really a comprehensive approach to delivering care for children and youth with special health care needs. And this started in North Carolina and Hawaii. By the time the 90s came around, the medical home became the standard of care for all children, and it really, again, began to encompass comprehensive care, recognizing that we are treating children and families in their communities and not just when they come into the door when they're sick. So the Maternal and Child Health Bureau, our federal partners, began looking at training practices in earnest starting in 1994. Kristen, next slide. By the time you get into the last decade, the medical home began capturing more attention from other medical societies, and so a PCMH joint statement was issued by the four medical societies you see there, the AAP, the American College of Physicians, American Academy of Family Physicians, and the American Osteopathic Association. And you'll see that it actually started looking at more quality of healthcare as well as healthcare safety. When you get into 2009, now the medical home has started entering federal law, and as the Affordable Care Act was enacted, in addition to increasing coverage for health insurance for persons around the country, it also provides financial incentives to shift patients to models of care that are consistent with the PCMH. It also provides funds to test these models of care and to see what these outcomes are. And the CMMI stands for the Center for Medicare and Medicaid Innovations. And CMMI has provided funding for groups around the country, including the state of Arkansas, to test new payment models and new models of care. Basically, this is saying, you know, we know that the current healthcare system, fee-for-service, is not really incentivizing good medical care, and we're looking for ways to incentivize good primary preventive care. So that leads us to 2014 with the Arkansas Patient-Centered Medical Home. Next slide, Kristen. So the PCMH, to go back to the 2007 Joint Principles, the 2007 Joint Principles from the medical societies say that the PCMH is a personal physician with a physician-directed medical practice that provides a whole-person orientation to their medical care. Care is then coordinated and integrated. Quality and safety are hallmarks of the PCMH. We provide enhanced access to care, which means that patients get 24/7 access or care when they need it at the time they need it. And finally, that there is appropriate payment for this model of care. Next slide, Kristen. And I think it is also important to recognize that we all already provide medical homes. You know, as practicing physicians in the primary care community setting, we provide the medical homes for our children and families. You know, we are identified as the go-to medical provider who provides medical care for children. So I want all of us to look at ourselves as providing medical homes And the issue with the PCMH rollout is how do we enhance our ability to provide comprehensive care, the care that we really know is needed for all of our children and families. Now, we're defining comprehensive care. This is actually an American Academy of Family Physicians definition, that comprehensive care is current prevention and management of multiple physical and emotional health problems of a patient over a period of time in relationship to family life events and environments. So again, we are providing medical homes. What we need is the support to provide the care we want to provide and be as true as possible to the principles of good preventive health care. And fee-for-service really, however, incentivizes doing more medical care and not necessarily keeping people healthy. What we're really looking at is how do we incentivize the healthcare system to keep people healthy. Next slide, Kristen. So the Arkansas Medicaid PCMH, and I've pulled these definitions directly from the Arkansas Medicaid PCMH slides and literature, because we are looking at how do we operationalize or how do we implement comprehensive care and align financial payments with this comprehensive care. So our PCMH is a team-based care delivery model led by primary care physicians who comprehensively manage patients' health needs with an emphasis on healthcare value. So the goals of a PCMH model in Arkansas is, the first is to encourage population health management. And that means that we take care of all of our children that are assigned to us as primary care physicians, regardless of whether they're coming in or not. We are responsible for their health. The second is to align financial incentives with good preventive care. And the third is to support our primary care physicians as key partners in reforming and changing the model of care so that we provide good care for our patients and families. Next slide. There are two terms that I would like to review because these two terms are going to come up over and over and over again. The two terms are practice transformation and care coordination. The first is practice transformation, which is adoption, implementation, and maintenance of approaches, activities, capabilities, and tools to encourage team-based care and population management. This really comes down to two separate things. The first is that it's all about population management. So it's about taking care of our kids when they are not, regardless of whether they're coming to us 10 times a year or whether they're coming to us 1 time a year. But it's also being proactive with patient care. Perhaps our kids that are out there, being seen once a year are very healthy, or maybe they have a lot of unmet health care needs and are going to the emergency room. But it is within our abilities to reach out to our families and bring them back to the primary care setting where we can manage their health care before they get sick. The second is care coordination, which is ongoing work of engaging beneficiaries and organizing their care needs across providers and settings. That means that all care must be seamless across settings, particularly for our children with disabilities and special health care needs. In other words, the highest resource utilizers need a lot more attention and coordination to make sure that their healthcare journey is seamless. As we know, our children with disabilities and special healthcare needs, they see the whole healthcare system. We know it's fragmented. We know it's difficult to navigate, but care coordination is our resource to help our families in that situation make that journey. Next slide, Kristen. So to really get down to the nitty-gritty, we're talking about changing or adding, I should say, payments in order to support practice transformation and care coordination. Because when it really comes down to it, we need to add or alter our staffing models in order to be able to provide this level of care. We're really looking at trying to make sure we have the services to manage our kids when they're in their community and when they're in their homes, not just when they come into the office. So the first kind of financial arrangement is practice support. And these are defined as payment. They're upfront payments. They do not replace any other payments that Arkansas Medicaid is providing. Upfront supports are payments of practices for care coordination and available support for the practice transformation vendor. These practice support payments are determined partly by risk profiling from a software package called Hopkins ACG. However, these practice support payments will pay about $4 to $5 on average, sometimes a little less, sometimes a little more per patient per month for your entire caseload of Medicaid beneficiaries. Again, they do not replace existing case management payments, and there is no change to existing fee-for-service. This is on top of what you already get paid for. Next slide, Kristen. Shared savings is the other financial incentive. These are payments made to a practice. These are additional payments to a practice that are made if certain cost targets and quality metrics are met. So in other words, at the end of the year, if it looks like compared to either historical benchmark costs, so how much you have your patient population has traditionally cost, if you lower your costs overall, or if you perform better than a median cost threshold. So if you are already an efficient practice financially compared to the median practice cost, Arkansas Medicaid will share some of that money back with you at the end of the calendar year. The greater of the two is paid to practices, and this is in fact intended to increase the bottom line revenue. And we'll show you some figures in a few minutes. Next slide, Kristen. These slides, the following slides are slides that are produced by Arkansas Medicaid, DHS, in their presentations to practices. And I want to go through just a couple of highlights through here. This first slide says, providers signal their commitment to transform by enrolling in PCMH through practice support. And this is just a little bit of information about what you do in order to enroll. The first is that you have to participate in a Connect Care primary care case management program and have at least 300 attributed Medicaid beneficiaries. The second is that in order to receive shared savings, so you can participate in receive practice support if you are a practice that has at least 300 Medicaid beneficiaries. So if you have 2,000 Medicaid beneficiaries, you can enroll and receive practice support. Shared savings, for this year alone, shared savings, you have to have a minimum of 5,000 Medicaid attributed beneficiaries for at least 6 months of the performance period. If you are a large enough practice, you can enroll and receive shared saving payments independently, or you can join with additional practices and say you're going to pull your your beneficiaries to become eligible for shared savings. Or there's going to be a statewide default pool for practices starting in 2015 if you do not have the minimum of 5,000 Medicaid attributed beneficiaries. So starting in 2015, all practices will be part of that shared savings program. So all practices starting in 2015 are eligible for shared savings in some fashion. Next slide. This is just a review of what I mentioned earlier. All practices receive practice support, which is an investment in primary care to improve quality and cost of care for all beneficiaries through provision of care coordination and provision of practice transformation. So that money that you get up front goes into your practice infrastructure. The second part on here is shared savings, which is rewards high quality care and cost efficiency by focusing on improving quality of care and incentivizing practices to efficiently manage growth and costs. At the bottom, it's also important to note that there are regular performance reports and patient panel information that enable you to look at your ongoing performance and your patient panels in order to enable improvement. Next slide. Practice support will provide monthly payments. Actually, I should correct this. We are receiving quarterly payments to support care coordination and DMS contracted vendor support for practice transformation. So what we are getting this year, quarterly payments, that is risk adjusted, and if you had 2,000 beneficiaries with $4 PMPM, you would get an additional $96,000 a year in practice support. On the right side, you'll see under practice transformation, there are payments that go directly to practice transformation vendor support. This year, the DMS recognized and certified practice transformation vendor support is through Qualis Health. And that means this support, however, is free of charge to the practice. So, and that is just part of the program, that if you contract with Qualis Health or or a certified vendor, that you will receive free practice transformation support if desired. Next slide, please. Okay. Shared savings. To get shared savings, you do have to meet certain benchmarks of quality, which are actually relatively there's relatively few of them, and we'll go through them towards the end of this presentation. But you can see at the bottom what shared savings mean for your practice. If you had, for example, a benchmarked cost of $2,000 and a medium cost threshold of $2,032, and your risk-adjusted cost of care, however, is less than either of those benchmarks. So you're talking either if your average cost of care was $1,900, your annual incentive payment that you would then get back from Arkansas Medicaid is almost $400,000. Or if it was $1,800 a year per member per year, a participating practice could get almost $700,000 in additional payments in shared savings at the end of the calendar year. Again, this is an upside-only model. It is not a risk-share model. So, we continue practicing with the normal fee-for-service billing and coding, but these are additional upfront payments for care coordination and practice transformation with the potential to earn additional dollars at the end of the year through shared savings. Okay. That is the end of the introductory kind of overview with language, and we're going to move into our experience to date. Are there any questions at this point about the program? It's kind of the nuts and bolts of what this is all about before we get into our experiences. All right. Kristen, next slide. Okay. The next few slides are, again, we've borrowed these slides from Arkansas Medicaid. At the beginning of this calendar year, they looked at the number of eligible beneficiaries, so the number of patients who have Arkansas Medicaid insurance, and found that in this year, the first year, that 71% of eligible beneficiaries were enrolled in a patient-centered medical home. So that is really a fantastic success for Arkansas Medicaid and shows the excitement that was following the program. Next slide, Kristen. In addition, 35 practices were eligible for shared savings. So not all practices that enrolled were eligible for shared savings, but 35 practices were eligible for shared savings. Some of those entities were created because they were pooled practices. They pooled with other practices. It does show you that well over 100 practices enrolled, but were too small under the 5,000 a year. The 5,000 beneficiary threshold were too small to be eligible for shared savings this year. But these practices chose to enroll for the practice support payments. Next slide, Kristen. For pediatric practices, we know of 47 practices, and we have communicated with a large number of them at some point to get their experiences and their understanding about how things are going, and also to get feedback from them, as well as being able to advocate for the needs of pediatricians. But the Arkansas AAP is directly working with 15 practices, and we offer for our members who are participating in the PCMH at no charge monthly webinars, weekly check-ins and contacts to see how things are going, to be able to answer questions and get feedback about how things are, what kind of things are going on within the practice. We have a listserv that we offer for anybody who is an AAP member in a practice and wants to join, and we use these to have to post questions and share experiences about how things are going with the PCMH payments and transformation. We also provide personal consultations. I have done personal consultations and presentations with practices, and also we are happy to also review data and reports with you to pinpoint where the opportunities for improvement in practices are. Next slide, Kristen. The AAP chapter also works directly with Arkansas Medicaid, the Arkansas Foundation for Medical Care, who is the quality assurance provider, as well as Qualis for providing practice transformation support. And the reason this relationship is key to the success is because it enables us as practicing providers and our office staff to have a direct line with the folks who have organized the PCMH rollout. What this enables us to do is share information up front with our members about what's going on regarding things like payments and measures and new developments. It also enables us to provide direct feedback to our partners at Arkansas Medicaid, AFMC, and Qualis about the things that are going on within the practice setting, regarding payments, regarding quality metric reporting, and we can get a lot of things solved with this kind of relationship and communication. Next slide, Kristen. So we've had some discussions about what folks are using these upfront payments for. So practices may get anywhere from tens of thousands to hundreds of thousands of dollars with quarterly payments over the first year. And these payments are being used for a variety of things. There is actually no restriction on exactly how you use these payments, and that is one of the best things about the PCMH payment initiative, is that it enables you to have the flexibility to apply the payments to what you think is best to help your practice. So some folks are using this for staff support, specifically care coordinators, dedicated care coordinators for their patients. It is used for administrative support for providers, either office manager or lead physicians. It is used for materials or training expenses, and some will use it for facilities, including redesign or expansion of their office space in order to reconfigure how they deliver health care. Next slide. One common question is, if we enroll in the PCMH, how much time does this actually take? Like, how much extra time do we have in our own practice in order to carry out all of the things that are being asked for within the PCMH? So our experience is that we recommend that you form a designated team or key contact for the practice. And it is likely that these folks may need a little bit of extra protected time, because what they will need to do is review patient data, either internal data or Medicaid reports. And this takes actually a little bit more time than most people realize. It's not something you can just glance at and then just move on. You've got to be able to take these reports and really understand where your strengths are and what your opportunities for improvements are. And that, again, is something that we at the chapter can help walk you through. Someone obviously needs to be responsible for being the key contact in a practice, and that person is responsible for making sure that metrics are reported on. And finally, somebody needs to be able to lead the quality improvement huddles and implementation of changes, which means that when you receive your additional upfront practice support payments, that you're able to use that the funds and protect your time, but just a little bit of time to be able to look at your data and implement changes in your practice in order to make sure that you are carrying out practice transformation. Having said that, practices are telling us that it really does not take that much time. It's certainly not taking people away, to the point where they feel like they are having trouble with their patient flow. And it's not a burden that practices are telling us is excessive. Again, likely because there's a lot of flexibility built into this. Next slide. the next thing that we want to discuss is what is actually changing in practices as a result. Like, what are you really doing in a practice that is going to change the way that we deliver healthcare within the practice setting? The first thing is that this program enables you to do a self-assessment of your strengths and weaknesses about how your practice is operating. So a self-assessment allows you to say, hey, we're really, really good at this thing. We're really, really good at maybe the hours or the access we provide, or we're really, really good at the teamwork that we have, the culture of quality improvement. At the same time, every practice has opportunities to improve. We ask in the PCMH and we discuss where are your strengths and what are your opportunities to improve. It's a really good opportunity to just take a good critical look at how your practice is operating. The second point is that this model of care enables you to look at your entire population of children. It gives you the data to be able to look at your entire population and say, is this child doing well? Is this child need more outreach? Is this child coming in when they're supposed to, or is this child going to the emergency room excessively? And does that offer an opportunity for us to bring the child in and intervene and promote health and wellness rather than reacting when the child gets sick? Again, population management means that we are responsible for all of our kids, regardless of whether they're coming in a lot or whether they're not coming in at all. But these payments provide us with the staffing and the data and the support to be able to do outreach to our patients who may not be using healthcare as efficiently as it could be used. The third point is that we, under the PCMH, are also now providing care management and care plans targeting children who require care management and care plans. What that means is that it provides us with the resources to provide extra support for children with disabilities and complex care needs and special health care needs. Support for us to be able to provide better access, care plans, care coordination, and education for families of children who are high resource utilizers, who are getting sick, who are coming to an emergency room, who are coming to the hospital, and it enhances our ability to take care of these kids because we know these kids take a lot of time and a lot of resources from us. The fourth is to really have us think about the medical neighborhood. And the medical neighborhood means that when a child and family accesses the healthcare system, they're not just coming into our offices. They're looking at the healthcare system with the hospital, the emergency room, the school, nutrition, WIC, pharmacy, many different components of the healthcare system that interact with each other. And the PCMH payment program asks that we take a good look at how our patients are using other aspects of the healthcare system and how can we tie everything together so that care is coordinated through the primary care home. Next slide, Kristen. How does this impact families? The first is that population management means that we are caring for children in their communities and in their homes, not just when they show up in our offices. So it's better care, it's better continuity of care, and it enables families to have better access to ongoing continuous care. The second is that services that our patients and families need and require, such as care coordination for children with special health care needs, these are services that can now be provided more easily because they will be paid for up front. The third is that this program enables practices to provide improved preventive care and surveillance of your child's health because it incentivizes upfront primary care and provides the flexibility for practices to redesign their practice, not just getting paid for if a child comes in sick. Next slide, Kristen. The financial impact is that there are more upfront dollars without financial risk. There's quarterly payments, but fee-for-service remains, so there is no downside financially. There is a potential for shared savings, and honestly what we are finding is that The practices are participating for the opportunity to change their practices and and make the changes that they really have wanted to do for many years in order to provide better upfront care for their patients. We are hopeful to be able to work with practices to realize shared savings. And there are opportunities that you can find just by looking at your data, and we can work with practices to think about how do we look for the opportunities for shared savings. It is not a guarantee to get shared savings by any means, and we don't want to mislead folks that shared savings is automatic. You do have to meet some quality metrics, and you do have to identify the opportunities. But again, this is a no financial risk situation that practices are in. And so regardless of whether you get shared savings this year, this also means that you will be eligible for the following year for shared savings, and this will be ongoing. Next slide. Okay, what is my responsibility at Arkansas Medicaid if you enroll? In a nutshell, at specific intervals, let Arkansas Medicaid know through an electronic portal what you are doing to change your practice. Or you just document that you're already providing good population management. There's an electronic portal, and you just have to report activities about every 3 to 6 months. You do have to meet a small number of quality metrics. Some of them are required simply to maintain care coordination upfront payments, and others are required before they'll give you shared savings. So the reason for the second bullet point is that we want to incentivize good care. We don't want to incentivize no care. We want to incentivize good care. Therefore, for example, you have to do a certain number of health supervision visits. A certain number of your patients have to have health supervision visits within the last year before shared savings will be given. That means that you can't generate shared savings simply by not seeing your kids. Next slide. This is just a table that shows the activities from 3 months at 6 months when we just passed 12 months and 16 to 18 and 24 months into the journey of a PCMH. And, we'll see this slide is available for reference. I don't want to read all of these points right now just to make sure we have time for questions. But everything that we need to be doing is laid out pretty well here. And a lot of what we just went through at the 6th month was documenting what are we doing and how do we plan to approach identifying a high priority patient, providing 24/7 telephone access, and how do we look at our availability of appointments on the same day. Next slide, Kristen. So the practice support activities. Okay. In order to maintain practice support, so the upfront practice support payments, the per member per month payments, we have to identify our highest risk patients, our high priority beneficiaries, and take a look at our practice and activities. We have to provide 24/7 telephone access. We have to monitor same-day appointments. We have to join share e-prescribing and electronic health records. We have to develop care plans for our high-priority beneficiaries and see them at least twice yearly. We have to see patients, a certain number of patients, of our inpatients. We have to see them within 10 days of discharge, and we have to work to make sure that only a percentage of our patients who utilize the emergency room or utilize it for non-emergent reasons. Next slide, Kristen. The quality metrics for shared savings. So in order to receive shared savings, we are looking at the percentage of children who receive well visits, and the remainder of these metrics, which are listed, are only apply if you have a certain volume of patients for which this applies. So, for example, most pediatric practices will have a sufficient number of patients who have asthma, and therefore you will be measured on the percentage of patients that prescribe appropriate asthma medications. Most practices will not have to be measured on percentage of diabetes patients who receive hemoglobin A1C testing. Most will not have a sufficient number of patients who have congestive heart failure, who are on beta blockers, and also most will not have sufficient numbers of patients who are on thyroid drugs. Next slide, Kristen, please. What kind of help will I get when I sign up? You can really get as little or as much as you want. This year we have one approved practice transformation vendor that is free of charge to the practice. That's Qualis. You also have quality assurance from the Arkansas Foundation for Medical Care, or AFMC. And we can't emphasize enough that we are all partners in this journey, and AFMC is responsible for chart audits and quality assurance to ensure that the metrics are being met. However, they are also partners in that our QA, what we encourage our practices to do is to discuss their challenges and their needs with their AFMC colleagues and reps up front so that we are able to meet the metrics together rather than seeing this as purely an evaluation. This is a learning process for all of us. Finally, the Arkansas chapter of the AAP, we are contracted to provide peer-to-peer support. We are doing this with you. We are doing this all together. We provide a learning collaborative, a listserv, and one-on-one support because we're all learning how to do this correctly. We all know what we want to do. It's a matter of actually putting really all these things into practice, including how do we hire staff, how do we train staff, how do we slice and dice our data, how do we interpret our data, and what do we do next? We share resources, we share ideas, and we also check in with each other about how things are going. Next slide, Kristen. So why do this? You know, this is really, if somebody asks us, why should we actually do this? And we've discussed this a lot at the leadership level of the AAP. The first point we want to make is that healthcare, not just in Arkansas, not just in Medicaid, but across the country, this is a trend, and we want to be at the beginning of this trend. We want to support everyone in providing this kind of care, because if it's not yet coming, it's already here, and if it hasn't arrived in your practice, it will arrive in your practice because our payer colleagues are going to ask for it increasingly. Healthcare is emphasizing population management and accountability. In other words, just good primary care and preventive medicine. The second is that financial incentives are aligning with this model of care. Primary care patients, primary care providers can get paid more, and in this model of care, we will get paid more with upfront payments. There is some responsibility that does come with these financial incentives, and that is something that we will work with you on. The third is that this is not just an Arkansas Medicaid or an isolated trial. A number of our private payer colleagues are also moving to this model of care. One other example is that at the federal level, it was just announced that CMS is starting to pay for complex care, chronic care management, which they've never done before. But in order to receive those payments, you have to have electronic health record and electronic care plans and certify that you have those in order to receive those care management fees for complex care patients. All payers are moving towards this payment model. We know that when CMS makes these payment changes, many other payers do follow. This is the future of how we are getting paid. It's a tremendous opportunity, but there are some changes and some growing pains that we will have as we make that transformation. But this is coming, if not already here. The last is that we are in a very unique situation around the country. These dollars to incentivize practice transformation and care coordination, they are not going to external companies. They are going directly to us. And they are going to us with a tremendous amount of flexibility. This is a situation which is pretty unique to Arkansas. We have the opportunity to show the entire country how it is done. We can show the entire country what happens if you incentivize and provide additional upfront support payments to primary care doctors. A lot of folks around the country are paying attention to what's going on in Arkansas. It's a very exciting time. It's a great opportunity, and it can be a little frightening at times because we do have to take those funds and figure out how we want to make the changes in our practice. But rest assured that we're going to do this together. Okay. Next slide, Kristen. For time reasons, I'm going to run through these slides pretty quickly. there is a PCMH portal, and we can send you or post the slides, and you can look and see how to get to these portals. The next enrollment period for calendar year 2015 begins on September 1st and runs until November 17th. All you have to do is log into the provider portal and follow the simple steps. You go to the enrollment section, you can see the highlighted box. Next slide. And you can download the enrollment form. Next slide. Fill out the enrollment form. Next slide. And submit the enrollment form. And that's actually all you have to do. I have heard that there may be some minor changes made to actually, if anything, make this enrollment even easier. Also, there is an enrollment opportunity will be made available at our upcoming pediatric forum, which will be held here at ACH on October 18th. And please contact Kristen for more details. I'm going to stop there. We can take some questions, but I do want to give Angela Luttrell from Qualis Health a few minutes to just discuss what Qualis has been doing with regards to the PCMH support. So Angela, go ahead.
Thank you, Dr. Quo. I'm not going to take up too much time, but I just kind of quickly wanted to run through our program and kind of tell you where we are and some of the work that we've done so far. So next slide, please. So just a little bit of background about Qualis Health. We are a nonprofit organization that was established in 1974, and our primary headquarters is in Seattle, Washington. Some of our consulting services include care management, which is focused around utilization management and case management. We do some healthcare quality and safety consulting along with health information technology. With regards to patient-centered medical homes, we've led probably about 20 states and helped over 1,000 practices become medical homes, which includes FQHCs, RHCs, free clinics, some academic medical centers, et cetera. And specifically, some of our clients have included the Harvard Medical School, Center for Primary Care, the Heartbeat of Texas Community Health Centers, and the LA Health Plan. Next slide, please. So in the fall of last year, Qualis Health was selected as the state practice transformation vendor for the Arkansas Medicaid PCMH program to develop and provide services for the practice support program. The content areas that the program focuses on, as you see here on the screen, are in alignment with the metric requirements that Medicaid has put in place for practices in the Medicaid program. Our approach is, the way we do our curriculum design and development training is to really, as Dr. Cole said earlier, to take on a proactive approach with our training. So we work with practices prior to the metrics being due, to give you practices enough room to get educated, for us to look at their processes, to work with their staff, and help them develop plans and do assessments and a variety of things to really try to prepare and ensure that they understand the program requirements, and if there's anything, processes that we need to work with them on to change within their practice, that the practice actually has time to do so. Next slide, please. So as Dr. Close stated earlier, once practices who are enrolled in the Medicaid PCMH program, they are offered at no charge to them a variety of consulting services. Practices receive 30 hours of one-on-one consulting with an individual coach. Prior to practices actually getting started, we also ask them to complete a needs assessment to determine where their strengths and weaknesses are, and have that ready to go so that when they have their initial meeting with their practice, with their coach, we know exactly what areas to focus on and help them to prioritize which areas they should focus on. Once that needs assessment is done, part of that is developing an implementation plan specifically for the practice. In addition to the 30 hours of one-on-one, we also do quite a few live online learning events, webinars. We record all of those and post them online to a library of resources that we have for practices. There's an event that's called an office hours where, you know, after you've had the learning event, if there was something specific that a practice didn't understand or specific to their practice, they're offered an opportunity to, in a collaborative manner, to get with our coaches and other practices to talk through some of those things that they couldn't address during the webinar. In addition, we have 3 in-person learning collaborative sessions, and this really has been a great experience for us and practices, and it's an opportunity for all the practices that are enrolled and receiving our services to come together to do some brainstorming, some strategizing, to talk about their challenges, to give each other ideas. We do some exercises and real-life one-on-one. We have panel discussions and a variety of other things that occur during that time period. Practices have really told us that they find these very helpful. Not only do our coaches do presentations, but we have a number of subject matter experts within the state and across the country that come in and give some feedback and some information about how to move forward in practice transformation. We just recently had our workshop number 2 here in Little Rock, and over 80 participants participated in that workshop, and was very informative, and so we've had some great results as a part of that. Practices are offered a library of implementation tools and resources. Some of those have been developed through our Safety Net Homes initiative, and then some of them have been designed that are very specific to Arkansas. We've done a PCMH budget tool. We've worked with Arkansas Medicaid and AFMC around a care plan guide template. We've had some practices who have been involved in the program also help develop a tool. There's a same-day tracking appointment tool that one of the practices worked with our coaches to develop that some of the practices are doing. So the program is really robust, and it is designed to be very specific to the individual practice needs. You know, some practices need a lot of support up front. Others need us at various points in time. Some of them want us to come to their practice on site, and others prefer to engage and interact via phone or whatever is most convenient and less disruptive for the practice. Next slide, please. We have 6 coaches currently that are working with practices across the state. We have approximately 67 PCMH practices that we are working with, which is about 100 site locations around the state, and all of them have on-the-ground experience, and they bring a wealth of professional experience around healthcare and patient-centered medical home content and health information technology. Next slide. So, you know, that was a very fast, quick overview of the program. If you have any questions, you can certainly contact me or email us at our information email account, and we will certainly we're glad to answer any questions. One thing I will say in closing is that in order to receive these services, a practice does have to fill out an enrollment application that's separate from the PCMH enrollment. So once a practice is enrolled in Medicaid PCMH, then they in turn will complete an application with us that asks some very specific information that lets us know kind of where you are and so forth. So for the enrollment period, after the enrollment period closes on November 17th, and shortly thereafter, practices can begin enrolling to receive support services for 2015. And that's it. Thank you so much.
Thanks, Angela. I really appreciate you being on a call with us today and providing that great information. We appreciate everything you do.
Thank
we
you.
are pretty close to time. I did want to give folks the opportunity to ask questions, however. We can stay on for questions. The mic's open for anything. Kristen, are there any questions? Yes.
Hey, it's Amy. I was just wondering, while we have folks in clinics that are kind of thinking through whether this is something that they want to be a part of, if they could, you know, kind of maybe share their reservations or hesitations or barriers that they're kind of seeing within their clinic that are dissuading them from being part of PCMH. If anybody wanted to kind of give any insight to that.
Yeah, Amy, I think the things that I have heard from folks range from a number of reasons, such as they missed the deadline from last time, but they were interested in participating. There have been, I've heard from folks that have had some differences of differing interests between folks that would be responsible for administering the program, such as between partners and administrators within the practice. Sometimes it's a larger organization, so there's a number of there's a number of steps that folks have to take in order to participate. Most of which I think can be worked through if we are, if we have folks at the table. But if anyone has heard anything else or wants to share some other experiences, we certainly would love to hear from you. So that's something that we can address head on. Well, it's 1:15, and unless there are any questions, I think we can close. Kristen, any details about this presentation being archived and contact information?
Yes, I will be emailing the recording of this webinar to everyone, and as well as the slides. And please feel free to contact me at any time. My email address is in the presentation and on the slides. If you have any questions or if you need any help with enrolling or anything else.
Okay, and I think with that, we'll call it a presentation. Thank you, everyone, for giving us some time, and we look forward to hearing from you and working with you.
Thank you, Dr. Quill.